Good afternoon. We're going to go ahead and get started. I'm live here on Zoom and on YouTube. Today we're going to talk about mainly just the next steps following practice or following your graduation. What do you do when you're getting ready to start practicing? What are your steps there? And just all the knowledge that I've gained through my years of career coaching and my years. So for transitioning from being a student to being a full-fledged APP, what do we do? What's the next steps? Let's begin. The topics that we're going to discuss today include boards, licensing, and credentialing, what your scope of practice means, protecting your license, job seeking and interviewing, contract negotiation, wage negotiation, mentorship, malpractice insurance, and time management. So we'll go over each of those things. So a little bit about me. I went to Charleston Southern for my undergraduate. My nursing background is in outpatient cardiology, inpatient telemetry, and education. I've taught at the LPN, ADN, and BSN levels. I then received my graduate degree from Clemson University. As a nurse practitioner, I worked for Minute Clinic. I need to update this. I currently work for Matrix Medical, and of course with NP Guide here. My passions are NP education, building confidence in new graduates, cardiology, antibiotic stewardship, Jesus and my family. I'm not telling you it's going to be easy. I'm telling you it's going to be worth it. So what is your biggest concern with the role change? Put that in the comment section below or in the chat section. What is your biggest concern with your role change that's coming up here? So which boards should you take? There are some live links inside of here that we're going to kind of run through. So this is going to talk about how do we pick which boards we're going to take next, things and resources to study, and how to list your credentials after you pass your board. So we'll start here, going into this document about the comparison between the boards. So this is also, you go to my website right now, np-guide.com. You can download this. You can have a copy of it. It's under student resources. So it's a little bit of information about the boards. I mean, it's pretty much anything you could possibly want to know, actually, comparing the two to each other. Some of the big things is AANP is a little bit shorter, ANCC is a little bit longer, a little bit more expensive. On AANP, it's all multiple choice, whereas on ANCC, it's mostly multiple choice, but there are some drag and drop hotspots, pictures, such as an EKG strip, chest x-ray, identifying a skin or eye condition, where you won't typically find that on AANP. Both of them, you get immediate pass-fail as soon as you finish taking the examination. There was a weird dip in pass rates of the AANP in 2022, where there was a consistently higher pass rate on ANCC. Another good benefit to taking the ANCC, even though it has a more wide variety of question types and is a little bit longer, a little bit more expensive, is that there's multiple ways to recertify, including continuing education, teaching, things like this. Whereas with the AANP, the way to recertify after 5 years is through practice alone. They have just recently added teaching. Some types of teaching can now qualify you for hours towards your recertification, but the AA or ANCC offers a little bit more range as far as recertification options if you don't anticipate working full-time as a nurse practitioner for the entirety of your career. There are other options out there. Head back to the main slide set here. On my present button. So then there's some resources. How do you list your credentials? So my highest degree is Master of Science in nursing. So mine is technically an MS, not an MSN, because of the type of university that I went to. The university itself awarded the degree rather than the nursing program. So it's a slightly stronger degree than an MSN. So I have an MS. My license is APRN. I'm an advanced practice registered nurse. In some states, it'll be certified nurse practitioner, CNP. So whatever your state calls it is what you'd use for your license. So I'm an MS, APRN, and then my certification is I'm an FNP-C. I took the AANP in 2018 when I originally became a nurse practitioner. So that would be my listing there. So the typical listing is MSN, APRN, FNP-C, or FNP-BC. But you do not include all of your, I don't want to see you listing your BSN or your RN or additional certifications It's the highest one only. We only need to have typically 3 things after your name. Sometimes I will see a 4th or 5th if it's relevant, like maybe a CCRN if they're trying to get their first acute care nurse practitioner position and they want to have that additional item on there, or wound care certification. I've definitely seen that added on. So if you're doing an additional skill, PMHNP, or an additional skill like wound care that took a certification to do, it does need to be listed as part of your credentials after those first 3. If you have, I had a question here in the chat. If you have a certificate that is relevant to your nursing degree, such as you're like a med-surg certified nurse or an oncology certified nurse, that does not need to be listed in your credentials after you begin applying for F&P positions, especially the med-surg one. I would only list the oncology one if you were applying to a hem-onc position as a nurse practitioner. So it would be in a rare case-to-case scenario that you would list a nursing certificate, but definitely not the med-surg one doesn't transition well to the next level. Good question. So how many nurse practitioners do we have? If you can see here, you can see that we have a significant increase over the past 20 years. We've tripled in size the number of nurse practitioners that are currently in the United States. Let's talk about licensing and credentialing. What are some of the steps that you can take to make this process go easier? Things that you might not think of that are necessary. You may need to do fingerprinting. You will need copies of your official transcripts. At times, those will need to be sent directly from the university. Other licenses, again, the APRN, that's going to renew every 2 years, but it varies by state. The controlled substance license, there might be a state level and a DEA license. So in my state, I need to be authorized to prescribe prescriptions. I need to be authorized by the state to do controlled substances, and I need a DEA license in order to prescribe schedules 2 through 5. A DEA license is state by state, so if you are practicing in 3 to 5 states, you need a DEA for all of that for some reason, such as someone who's a PMHNP who's working virtually via telehealth and needs the ability to write Schedule 2s across state lines. You would need a DEA license for each state that you're in. Your NPI is another license that you'll eventually need. The F&P taxonomy code is listed here. You can easily look up the ones if you're a different specialty. Primarily, I recommend waiting until you have your first F&P or NP position. You've already hired for it, so that you can use the address of the facility at which you are going to work. Because if not, you have to list your home address and phone number, and that's not what's intended to be listed there because it goes into a public registry that can be found on the internet. You don't want your home address and phone number out there. So wait until you get your first job, you've officially been hired, to fill out your NPI. It only takes, it's almost instantaneous. You don't pay for it. It's not merit-based, no testing required. It's just a number that's necessary for you to do some certain things with insurance. So you don't need to rush to get that one. It's not going to put you ahead of everybody else if you already have your NPI. So just wait until you get your first job and do that one. When talking about credentialing, a lot of people say, oh, I'm scared of that process. It sounds like it's going to be difficult. Most, if not all, of companies that you are going to be hired by, your employer is going to do it. And they're going to credential you for local payers, government-based payers like Medicare and Medicaid, TRICARE. So under local payers, that's going to include things like Aetna, Blue Cross Blue Shield, things like that. But the employer is going to do it. They do need some information from you. So you're going to need typically to have your CV, a full CV with all of your work history, not just the last 10 years of your work history or something brief like that. They're going to want the full version. A color copy of your diploma, your NPI number will be needed at that point, that's fine. Again, you can get that same day. DEA if you have it and need it. The proof of your certificate, driver's license, social security card, birth certificate, and that you have malpractice insurance. And this is what will be needed to submit to your credentialer at your company for them to go into CAQH, which is a software that most places use to credential you. They will ask you for your username and password. You will give them your username and password. Just make it a password different than something you normally use. They're going in there and acting on your behalf. This is a normal process. Don't be alarmed if someone asks you for your username and password for CAQH. Again, just use a unique password that you don't use for any of your other login information, just to have that layer of protection there. So go ahead and get some of these things ready. You do not need to credential yourself. Do not stress about that, but do have those things ready, saved in a file folder on your computer so that you're ready to go when that starts and you're hunting for things or being stressed by that process. Plan ahead. Scope of practice. So in each area of the country, there's different types of practice regulations, and that is developed by the state law and nurse practice acts, and those are created by the boards of nursing for each state. And embedded here is a link where you can see what's going on in each state. And this is on AANP's website, so you'll be able to go and find that quite easily. And you can actually select your state. So I live in South Carolina, so you can kind of select your state and kind of see what's going on there. Practice information by, per state. What kind of practice are you considered? We're considered restricted. And then just like what's going on in your state, who's representing you, things like this. And so that can be found on the AANP site. Just to have an idea of that. If you're wanting to do something like telehealth, the green states are probably more effective. It's really state by state as far as telehealth working. You can't really do a lot of telehealth in South Carolina. It's not on the recommended list of licenses to get if you want to practice in telehealth. Typically, we recommend for telehealth nurse practitioners to have 1 to 2 years of experience in a physical clinical setting, and then to seek 5 to 10 state licenses, which could be a lot to handle. It's a little bit of an investment, but you do get a little bit more flexibility in telehealth that some people find that to be valuable. But there's a list of states that are recommended to get, and South Carolina is definitely not on that list. So knowing a little bit about the culture of each state can be helpful if you're determining where do you want to move, what states should you get licensed in if you want to be a telehealth nurse practitioner. So that can be useful information. We're frozen. We went forward a couple, too many slides there. So what state do you live in? What type of practice environment will you be participating in? You can put that in the chats or the comments. So protecting your license. Let's talk about malpractice. So what are the most common medical malpractice allegations out there? Failure to diagnose, so something that should have been caught and wasn't diagnosed or treated properly. Improper prescribing and managing of controlled drugs, which leads to addiction. Failure to timely or properly establish and or order appropriate treatment. So you identified a diagnosis but didn't for some reason initiate the diagnosis or the treatment plan as typically expected. Failure to document or perform a patient assessment. Documentation is probably a big step there. And also there is a major issue with providers walking into a room, asking 4 or 5 questions and walking out and not really laying hands on the patient, going in and charting, heart rate regular, rhythm, lung sounds clear, stomach soft and non-tender, but they didn't touch the patient. Make sure you're actually touching your patient, charting properly, documenting relevant negative findings and positive findings. You need to say, I didn't see these problems. I did see these problems. Having the I didn't see these problems listed is very important, because if you're justifying sending somebody home rather than sending them to the ER or referring them to a specialist, you need to chart the absence of significant findings, like no left lower quadrant pain, no right lower quadrant pain, no fever. Those types of things need to be charted so you can justify sending them home. Next would be the failure to recognize contraindication or adverse interactions between ordered medication. And lastly, failure to order appropriate tests to establish a diagnosis. This is a chart that is specific to people who are MDs or DOs, but we need to know what's going on in the MD-DO world, because those things are going to translate over into the NP world as far as what kind of suits are we expecting. 55% of physicians have been defendants in a medical malpractice lawsuit, either alone or with others, and 49% of defendants have been sued 2 to 5 times in their careers. The most frequently sued specialists are surgeons, OBGYNs, orthopedists, plastic surgeons, and otolaryngologists. So this can give you an idea of the higher risk types of specialties. If you're considering specialties, you want something lower risk, you could consider not choosing one of those 5 specialties. What doctors pay for medical malpractice per year. So this can give you an idea of how much policies typically cost. 30% of people pay less than 10,000. These are physicians. They do typically pay more. So 10,000 or less, about 30%. And then we got about 25% who pay about 10 to 20,000 for malpractice insurance per year. And then a remaining 20% kind of get pretty high up there. 24% of the doctors interviewed in this setting did not know what their premium cost was, probably because their hospital was paying it for them. So you can't just be sued for any little thing. Someone cannot walk into a patient room and say, I'm going to sue you for not giving me antibiotics for my virus. They can try. It will not work. Business managers still don't want that to even come out of the patient's mouth because of, ratings in Google and Yelp and all that, which is silly because it promotes bad practice. But you can't be sued for that because there has to be 4 elements to exist for it to actually be considered a malpractice. Duty, there's a provider-patient relationship must exist. So it can't just be somebody on the street. It can't just be a friend of the family. It can't be somebody else's patient within the clinic that you just came in and talked to briefly. Weren't included on the charting or anything like this. It wasn't a true consult or anything like that. So there has to be a provider-patient relationship. So if you know of a patient who's had issues at other clinics and you refuse to take them as a patient, there is no provider-patient relationship there. They can't sue you. Next, there has to be a breach. A standard of care was not met, and we kind of talked about those on the previous page as far as what kind of standards are typically the main issues. So here, standard of care was not met, caused, an injury was caused by the error. There does need to be an injury and a harm, a damage, so to speak. Other than that, it's more of a near miss type of situation. So that's what needs to be present for it to be malpractice. An actual harm came to the patient due to a neglect that you had, and you were obligated to provide that to the patient. What is causing the recent increase in malpractice? Definitely the climate. There is, unfortunately, a very sue-heavy climate that is not typical to other healthcare populations in other countries. We are also caring for more complex and chronically ill patients. They are having more comorbidities. Our patients are living longer and are having more healthcare problems because we're increasing lifespan, but not necessarily health span. So we are dealing with complex, chronically ill patients. Also, we've tripled in size over the last 20 years. We're expanding into more specialty areas, and we're increasing our responsibility and gaining full practice in more states. So we're not necessarily being covered by a physician as well when you're in those full practice settings. Prior to that, if you were in a collaborative state and you have a collaborating physician, that physician bears some of the responsibility going forward with malpractice. But with full practice, again, that you are more open as a target, so to speak, because you have that increased responsibility. So I think that there can also always be the issues of education within the nurse practitioner world, especially right before, during, and after COVID, where we saw a pretty significant dip in the quality of education, especially with clinical rotations. So we have people who are coming out possibly underprepared at the time. So there is a little bit of concern there. How do you protect your license personally? What are steps that you can take to make sure you don't end up in a lawsuit? First, scheduled drugs are such a big one. Use the state's prescription monitoring program. Make sure that you are verifying that the patient is not receiving prescriptions for controlled substances from multiple clinics. Prescribe for your patients and not someone else's. Do not cover someone else's patients in the clinic. If you hold the DEA license and 3 others don't hold a DEA license, and they're asking you to prescribe all of the pain medications and controlled substances for somebody else's patients, kindly refuse and encourage them to get DEA licenses for the additional practitioners in the clinic. Make sure you have malpractice insurance. Communicate. We need to be honest about the state of medicine. If you're being honest with your patients that we don't necessarily know what's going to happen when we try this medication, here's the expected outcome. Here's what I expect to happen, but I can't guarantee that this will happen. I can't guarantee curative. I can't guarantee that this will work. I can't guarantee you aren't going to have an adverse reaction to this. And so we need to be honest about the state of medicine, that we're experimenting every single time we give a new prescription to a patient. It is a little experiment. We have a reasonable expectation of what probably will happen, but we can't guarantee results. Make sure you're documenting as if your life depended on it. Stay up to date with current trends in healthcare, making sure that you're going to conferences or reading journals, especially for the most common chronic conditions that you're seeing, that you're frequently reviewing the guidelines for those annually to make sure that you are adjusting your care based off of new medications, new findings. Timely and appropriate follow-up. So if you've got a patient with pneumonia and they're older, a little bit of kidney dysfunction, we're giving them some antibiotics, but they've also maybe got a little diabetes, who knows what's going on. We have an appropriate follow-up. You're seeing them within 48 to 72 hours to do a follow-up examination to make sure you don't send them home and they're actually worsening over time and they're just waiting for the antibiotics to work. We need to have an appropriate follow-up. Use your resources, use the superiors in your clinic area, those who have much more experience. And this I'm talking about first year NPs here. Be humble, be honest if you're struggling in an area. Make sure you're doing your due diligence of research once you get home at the end of your day and spending time after your work shift researching things if you struggled with the topic for the day. And then making sure that either your collaborating physician or other more experienced NPs and doctors within your clinic are available for asking questions. Avoid the EHR trap. So remember, EHRs contain a timestamp. When you documented, when you reviewed previous records, and how long you spent on reviewing and charting before or after the visit. It can actually show how much time you spent looking over that chart. If it shows a hurried review, it can reflect negatively. Also, they can track where you've clicked. If you dismiss a computer-generated warning and you override the system for diagnosing or prescribing medications, especially those that maybe interact and you don't have a good explanation in there, that can also be a ding against you. So if you have an issue, you find that you are going to be part of a lawsuit, get good legal advice early, listen to it, tell the truth, and be careful at your depositions. Let's talk about different types of insurance policies. So we've got claims-based policy and occurrence-based policy. A claims-based covers claims made and reported during the policy period. After the policy expires, there is no coverage. So if last Tuesday you made a mistake and you retired today, your policy ends. Let's say in 2 weeks, that problem that you had last Tuesday comes up and they are going to sue you for it. You're no longer covered. Your insurance won't cover you for that because you've quit the job. The policy has ended. If you have a claims-based policy and that's what your company is paying for and offering, you need to also purchase tail coverage, which is what will extend the policy beyond the expiration of the initial claims-based policy. You need to purchase the tail coverage. Occurrence-based policy does not require tail coverage. It covers any incident that occurred during the policy period, regardless of when the claim is made. So if you made a mistake 5 months ago, quit the job, moved to a different job now, have a different policy, it will still be covered under this occurrence-based policy. You do not need tail coverage for that. Let's go into job seeking. How do you find your first position? And I do have another question. Should we keep our nursing certificates active once we become a nurse practitioner, like a med-surg certificate? No, it's okay to go ahead and let those lapse. At this time, it's time to pursue advanced practice certificates. If you want anything in addition to your NP, again, something like wound care, if you go back and get a PMHNP or you become certified in palliative care, there's lots of certificates that you can get and use that outside of your primary FNP certificate that translate to advanced practice. Keeping your med-surg nursing certificate is not necessary. If you, for some reason, anticipate staying a nurse or working as a nurse while you're being a nurse practitioner, possibly, but for the most part, it is perfectly fine to keep that lapsed. All right, so back to job seeking. There we go. Let's talk about CV versus resume. So for most most people at this level, I recommend a CV. Most people's work history does not fit on 2 pages, which is about as long as I'd let a resume go. A resume is max 2 pages. So if your current document goes over 2 pages, right now you already have a CV. And a CV does cover all of your work history. It includes leadership positions, if you've been on a committee, if you written any papers or published any papers that you want mentioned. It includes, the long description of your clinical rotations. A CV is most appropriate at the MSN level, and it's necessary basically at the doctorate level. So that would be a good thing to consider. You also need a CV for credentialing. You need a CV if you're going to apply to residency programs or fellowships. Really recommend using a CV. And again, if your current document's already over 2 pages and includes all of your work history, you're on your way to having a CV. You're getting there. Do I recommend a cover letter? Yes, at this level, I recommend a cover letter. In nursing, not so much, but as an APP, I do recommend having a cover letter. I recommend applying for any position, even positions you do not have experience for, because you never know what kind of networking opportunity you might have. Your experience in a nursing field may correlate well with the experience needed for that position, even though you haven't had any specific NP experience. So apply for any position. You never know. And they almost always have someone from HR call you first, ask you a few questions, and decide if they even want to move forward with a formal interview. So there will be a screening call to kind of work out if you are eligible and if there's any negotiation room for some of those things. Make sure you network. A lot of people get their first position through networking and, applying where they precepted, where they are currently working as a nurse, friend of a friend. So network as best as you can. Get your CV out there to those individuals. Be objective. It might take a little bit of time. There are some areas of the country where there are just not as many jobs available. There maybe is too many nurse practitioners, or there's not enough funding to create more positions, even though there are patients there. So give yourself grace and time with that. Be persistent. Keep applying. Keep moving forward. Timing. People ask me, when should I start applying to jobs? And so I always say cast 3 nets. The first net, you can start applying anytime. Right now, even if you're in your second semester, because it could be more of a networking thing, getting your name out there, especially if you're talking about sites at which you are currently precepting. That's kind of your first net. You might not really get anything, or you might get a working yes. It's a possible yes. When you graduate, we will hire you kind of a situation. The next net is after you graduate, you finished your schooling, you can start applying again more aggressively. You might not hear back at that point if you've not yet passed your boards and don't yet have your state license, because they don't want to wait for you to get your ducks in a row, and they want you to start within 2 weeks. Okay, so there's a lot of positions like that where they may need you to start sooner than it would be possible for you to, either due to graduation, boards, something like this. So it's not an offense, it's just a timing issue. Make sure you stand out, have an excellent professional summary at the top of your CV where it makes them want to read more. Follow up. I always say if you can follow up or reach out, use LinkedIn or go in person, any of those things to try to make a connection to a person so that you can get that virtual handshake and, even ask for time. I got an interview once by emailing back the recruiter after not really hearing anything for a couple of weeks and saying, hey, I'm available on Tuesday and Thursday from 1 to 5 o'clock to interview. And I would love to get that set up. I'm really interested in this position. It's right aligned with what I want to be doing with my career. So could we get that set up? Here's the times I'm available. And that's a little bit more than just saying, hey, have you looked at my resume? Are you interested in hiring me? It's a little bit more, let's get this interview set up. I'm ready to roll. It's quietly assertive. Where do you apply for jobs? What places have you been using so far? You can put that in the chat or the comment section there about which sites have you been using so far to apply for jobs. Interviewing, what kind of things do we need to think about when we're talking about interviewing? So there's a bunch of different things that can be done. Of course, first time you typically get a screening call with HR where they just kind of make sure that you fit for the position. I work per diem right now for a company, and every now and then I might see something that's a bit interesting, or I might consider adding on as a second per diem position. And so the screening phone call comes through and they're like, oh yeah, we'll have you travel to this clinic, and this clinic. And I'm like, okay, well, only one of those was listed on the job description. I'm not willing to travel that far. You know, it works for both ways. We want to be good for each other. I want to like the job and they want me to be appropriate for the job. So those screening phone calls are helpful to kind of quickly weed out whether or not you want the position or if you're even eligible for the position. So video interviews, I've had several video interviews over Zoom. Um, and, you know, that's just such a common way of communicating now that it feels almost second nature. There can be on-demand or digital interviews, like with HireVue. This is what CVS uses. You get questions on a screen or from like a AI robot voice, and you record your answers to that. Or you could have a traditional in-person interview with anywhere from 1 to 5 people. And if you have the in-person interview, there's usually several steps to that. You may meet with one department and then the actual clinic. You may meet with a couple of the nurse practitioners and then maybe the person who's in charge of the clinic, the hiring manager. So there's different steps to those in-person interviews. So there's a lot of behavioral interview questions now. It seems to be kind of the common trend is that there's behavioral style questions. A lot of tell me a time when. So we're going to use the SAR approach to answering these types of questions. You're going to start you're going to open your story with a brief description of the context, then you're going to give action, highlight traits and skills like initiative, leadership, time management that allowed you to accomplish the task, and then results, conclude it with the positive outcomes. You want to emphasize a positive or measurable result from that. So again, those behavioral questions are things like, tell me a time when you dealt with a difficult patient. Tell me a time when you dealt with a difficult peer at a physician. If a patient is demanding antibiotics from you, what would you do? So those types of questions. So making sure that you give good context, kind of go in a good order that has good flow, good context, point out good skills that allowed you to succeed in that, time management, being straightforward, being honest, being kind, whatever it took, whatever trait or skill allowed you to accomplish that task that's positive. You know, discuss those and slide those positive things into that question. And then typically you want it to have a positive ending. So find a good story from your clinical rotations where maybe you talked a patient off the ledge, so to speak, of demanding pain medication, demanding antibiotics, how you were able to calmly redirect that, address the patient's actual symptoms, help them actually feel better, validate that they feel sick, you know, but you still ended up with the positive outcome of you didn't inappropriately prescribe antibiotics to that patient. So making it a positive at the end of it. All right, let's say that you've got the position, you aced the interview, now you need to negotiate. What is important to you is the most important part of this. There's the base compensation package, which is going to include things like your salary, your bonuses, RVUs, potentially benefits, and you have to decide what's more important. Do I want more money or do I want a lot of benefits? Do I want them to pay me a little bit less because they give me more support staff or something like this? So let's look at some of these things that can be considered when we're thinking about negotiations. So what is going to be my scope of practice and responsibilities? Am I going to be working at 3 different clinics and having call? Am I going to be managing a huge patient load? Am I going to be expected to see 25 patients per day? What's my appointment time? Because if they're asking you to see more patients, you should be getting paid more because they're bringing in more money if they're requiring you to see 20 patients a day versus 12. Okay. Admin time, or am I going to be given a few hours on Wednesday and Friday afternoons to catch up on charts? Do I have support staff? Do I have an MA, a nurse, someone who's handling prior authorizations? What kind of support staff are going to be here? How long will my training be? Unfortunately, for most nurse practitioner positions, if you're going into primary care, urgent care, internal medicine, you actually only get about a couple of weeks of training or orientation, and that's just to make sure you understand the policies, procedures, and charting system of the facility at which you are being hired. It is not a lengthy orientation. They expect for your clinical rotations to have been enough for you to be able to kind of walk in and practice. So there is that, but you want to make sure that there are people around, peers, mentors, especially for that first year, that will help you make good decisions when you're stuck with a tough clinical call. What does the work schedule and call look like? Do I need to take call? What does that look like? Do I get reimbursed for call? Is it going to be I'm taking phone calls from 5 p.m. to 2 a.m.? What is this going to look like? And then is that part of my salary or is that an additional payment that I'm going to receive. CME money and CME time off, anything from $1,500 to $2,500 for CME money is fine. That can get you a good couple of conferences. And then the time off, 3 to 5 days, so that you can at least get one good conference in. PTO, how do I accrue it? Is it accrued over time? Is it standard package? Does it include sick days? Does it include, what all does my PTO cover? Malpractice insurance, are you paying for it? Am I paying for it? Is it claims based? Is it, occurrence based? What type of insurance are you willing to give me? Does this contract have a duration? Do I have to be here for 2 years or pay some sort of penalty? Do I have a non-compete clause where I can't practice within this same area for a year if I quit this job before the contract is up? Is there a termination clause? You can also ask them, if they ask you the question, what would you like to be paid for this position? You can ask them, what is your budget? If that doesn't seem to be going well or it feels too bold for you to say that, if they come back and say, we'll give you 105,000 for this position, counter up 15, say I'd like 120. The least they can say is no. No, we can't afford that, unfortunately, but we still have this is what we can offer you, 105. Would you like to take this? And then you can say yes if everything else looks good enough and you're ready to take the position. If I don't want people to ever be scared that they're going to rescind the offer if you ask more money. If someone rescinds an offer just because you asked for an additional $10,000 to $15,000 per year, you probably weren't going to get any raises anytime soon, and we're probably going to be overworked. So for me, it's almost a litmus test if they won't at least keep the previous offer, if not bump it up a little bit. If you have been searching for a very long time and you're just nervous and you need to get your first job, I mean, it's up to you whether you take what you're handed as far as that first contract they put in front of you and you take it with all of its, annoying little things that you might not like, or if you're willing to negotiate that. Negotiation is expected in the business world, so it's not unexpected, rude, or things like that. It's something that we could improve upon as a profession. Some other things to consider is, are you going to be paid hourly versus salary? So, or per patient, because there are per patient jobs as well, and you can kind of work out the math on that. So a salary of $75,000 equates to monthly pay about $6,250, weekly pay of about $1,442, and an hourly wage of $36. So if you're being paid $75,000 a year, which can occur in states like Florida, you're only making $36 an hour, unfortunately. On the flip side, you want to think about what you're making as a nurse right now. What do you want to make as a nurse practitioner? If you want to make $54 an hour, you need to ask for about $112,000 per year. Education level does not affect compensation for the most part. That's not universal. FNP is an FNP. For the most part, MSN versus DNP does not increase salary. It might give you a leg up. Maybe you'll be hired over someone with an MSN, but the compensation typically doesn't change. Another benefit to the DNP is, of course, if you're wanting to teach, you will need that doctorate. On average, FNPs make about $124,000 a year, and that's across all levels of experience and specialties. Okay, region and cost of living do matter, but it doesn't always affect the pay. I did an analysis last year to look at cost of living per state and the average pay that the nurse practitioners were making in the states, and it didn't perfectly correlate. In some states where you would expect for the nurse practitioner to be paid more due to cost of living, the salaries were unexpectedly low and vice versa. And then lastly, are we truly oversaturated? I mentioned that number earlier today, that we've tripled in size as a profession since in the last 20 years. And we're often quoted this line of, there's a shortage of primary care providers, and we need to get more doctors and more nurse practitioners. That number that's been released by the government is a theoretical number. It is a number for what they would like to see. They would like for there to be X number of nurse practitioners and doctors per patient population in America. But that does not mean that those jobs have been created or that the money is there to hire that many nurse practitioners and doctors. So there's this theoretical shortage. And so I think a lot of people are very shocked to be told this over and over again, that there's a shortage of nurse practitioners and doctors, only to come out of school and not be able to find a position. And it's because the shortage is there, but the jobs aren't. Okay, they just want the nurse practitioners and doctors who are already established to see more patients, take on more responsibilities and things like that. So that's kind of the mismatch of, is there a shortage or are we oversaturated? So how do you feel about the job market in your area? What's going on in your area? Do you feel like it's going to be a little bit easier to get a job, or is it a bit more saturated where you are? All right, nextly, let's talk about the support that's needed as you transition. The partnership and collaboration aspect of being a first-year new graduate. So it's absolutely essential. You respect those educations and experiences around you, know your limits, and find a mentor. So what can we do as far as little things throughout our day to make our days run more smoothly, and time management? Because that's such a hard part, is you're being asked to do a lot of things all at once, and it's brand new to you. So how do you manage your day as not a student, but as the primary provider? So when you're in your first year, you may need to start by checking your charts the day before. I've been a nurse practitioner for 6 years, and I still try to take the time to review charts when I have the chance, because it just makes the next day go a little more smoothly. And there's new medications coming out frequently. There's medications that have come out in the last year or two that are popping up on charts, and I need to take a little bit of time to go and read more about that medication because it's new and I haven't seen it before. If it ends in MAB, I'm like, I have to Google it, because there's like hundreds of them and they keep coming out with them. Chart immediately, chart as you go as much as you can. If you need to leave the chart open just to proofread it later, I definitely do that. I try to chart as much as I can on site when I'm in the appointment, and then go back and proofread if I need to, just to make sure all my ducks are in a row and I have all my ICD-10s in where they need to be. Build your templates. There will be times when I find myself typing in the same thing over and over again. I'm like, why have I not made this a dot phrase? It would take me 45 seconds to make this a dot phrase in Epic, so I could stop typing the same thing over and over again. So put the investment of spending 5 minutes on creating a template that will probably save you hundreds of minutes later. Inbox management, try to find the best way for you to manage your inbox, whether you're able to stop between every third appointment, take 10 minutes after lunch, while your nurse is working up your first after lunch patient, to look in your inbox. Find a good way to manage that inbox. Delegate what you can to your MAs, your RNs, and your support staff as far as paperwork and things like that, prior auths, getting prescriptions refilled. Delegate what you can to them. Work with the scheduler and the clinic manager if it feels out of touch with reality, what the expectations are. I'll definitely see people say, okay, you're giving me this back to back to back and only giving me 15 minutes each for these. And then you're giving me this other appointment time, which takes me basically no time, but you've blocked off a huge portion of time for it. Can we readjust the appointment times, make this one a little bit shorter, make this one a little bit longer? Kind of try to work with the scheduler and clinic manager to see if we can't make the appointment times make a little more sense, with a little bit of give and take on each end, hopefully. And this to me is such a big thing. I think this one I'm just teaching to myself. Do the thing that takes 5 minutes. Like, get that thing done, especially first thing in the morning. If there's some task that will only take a few minutes, do it. Start your day off in a positive thing where you can complete a task that's short, maybe a little bit annoying, you don't really want to do it. Go ahead and get it out of the way, get it checked off, and just do that thing. As far as the appointment itself, when you're in there with that patient, you can really only handle 1 to 2 chief complaints at a time. So if you're doing more of a chronic disease management, you're kind of quickly going through the labs, adjusting medications as needed, and then maybe addressing a new issue or a new symptom as a part of their chronic diseases to see if you can help alleviate something new or changing with those things after you kind of get your business taken care of with titrating medications based off of labs. And then you're going to need to take control of that appointment. If there is too much talking, I have found with the talkers, they aren't necessarily even really offended if you just kind of end it and you thank you for telling me that. I've got to go to the next patient, and you just keep moving. There's not typically a large amount of offense. They enjoy talking to you. May not feel cut off necessarily. So it's just kind of like, you got to keep the pace up. Maybe you send your nurse in there afterwards to wrap things up and hand them their papers so that you can keep moving. But setting expectations, I try to tell people how long I think their appointment will take. Sometimes I'm right, sometimes I'm wrong. But I want to give them an idea of, I've got about 15 minutes to spend with you on this issue. I need to take care of these 2 things, and then I'll have some time for some questions at the end. And so that can kind of give them, okay, she's got to talk first and handle stuff, and then I'm going to have time to ask my question. So you've set up the expectation for what the appointment's going to look like. Another thing is doing it in the same way, in the same order every time, so you get this routine going, especially with your HPIs, your reviews of systems, your physical that you're actually doing, if you do it in the same order every time, you're going to find yourself not skipping systems, not having to go back into rooms, and getting it in that order. I like to base it off of the chart. If there is a fluid order to the chart as far as like the click-throughs of things, try to match your order of your physical to the order of the chart. And plan of care development. Know that it's a process over time. You may end the appointment with an open-ended question of what do we do next? You manage the thing, of course, that's going to mess with them first. If their thyroid level is like a 14, we're obviously managing that right now. Today, we're going to adjust the Synthroid. And then we might not get to one or two other things that weren't as involved or life-threatening. And you say, I'm going to see you back in 4 weeks because we need to check your TSH then. I know you had some questions about this. Here are my initial thoughts on this. I think we can address that at this appointment in 4 weeks, or give them another prescription for something else. And I'll also check on the therapeutic effectiveness of that in 4 weeks. So you're developing things over time, because we also don't want to do too much to the patient at once either. We don't necessarily need to initiate tons of medications at one time, because then we're going to have a hard time deciding which medication is causing the diarrhea. So it's kind of helpful to let these things kind of slowly develop over time. We're addressing, of course, the thing that's going to be the most problematic for their long-term health outcomes, and then slowly trying to build up towards the best quality of life and health that we can get this patient. Charting tips. So the MA and the RN does the HPI and the ROS in a lot of clinic settings, of course. You do have to double check that, kind of go over it. Sometimes you'll get a completely different HPI once you walk into the room versus what was initially charted, which is always fun. Again, same way every time. Use your templates. Master your SOAP notes now while you're a student, even though they're boring and long, and sometimes you have to type them out or handwrite them for class credit. It is helpful. I think it's a great thing to do. Another good way to chart faster is if you copy the previous chart and paste it in. So like if you're doing a problems-oriented charting method where you have a list of like their 10 problems numbered, and you are just kind of copying everything over and then adjusting, saying no changes or titrated medication up 25 milligrams, and kind of charting in that way. That can be helpful to save time. Make sure you use standardized terminology, not red and bumpy, but erythematous, vesicular, so that the next person who picks up the chart knows what you're talking about using those standardized terms. Again, appointment tips, again, routine. Routine is so important. You get it done in the same way every time. It becomes rote. You stop skipping things. You save so much time. And if you find something's not working for you, change your order and try it out for a little bit and see if it helps. Delegate patient education if you can. Manage the patient expectations from the beginning. Like I said, I need to take care of these few things. That's always helpful. I need to ask you these questions. I need to do a physical assessment, and then I'm going to have some time for questions for anything new that you want to talk about. And so managing those expectations has been really fruitful. And if you need to step out of the room because you have a question or you need support during that, especially in that first year, I'm going to go look over your chart and come up with a plan of care. I'll be back in a few minutes. You need to take the time to step out of the room and learn something new. So what kind of challenges do we expect to see? We're going from expert to novice. So we might be an expert registered nurse, but we're going back to a new graduate level, a new novice. And so we have to kind of start at that place, recognize that, but also think about the confidence that you have. You do have years of assessment. You do have good clinical judgment. You're just applying it to something new. Have confidence, understand your roles, your resources, and your responsibilities. Mentorship is necessary. It's hard to find. So do the best you can in finding what that is going to look like for you. And then I think one of the biggest challenges in that first year is you kind of feel this moral burden a lot because you don't feel like you can do everything that you want to do for your patients. And so combating that increased level of responsibility and that moral burden sometimes is more taxing than other parts of the job, and kind of unexpectedly. So I see that quite frequently of a concern. It's like, I've got all of these requests from patients. I'm not able to handle everything. Some people are in bad situations. I'm not able to spend as much time as I want on the patient. I don't know as much as I could know to help this patient more quickly, so it's slowing me down. So you work yourself into this place of heavy moral burden. And you have to continuously combat that by saying, have I made a positive step for this patient? Have I taken one step with this patient in a positive direction? Yes. Okay. I can keep taking those small steps. I can't fix them today. I can't fix all these problems today. I can't deal with patients. I can't fix a patient who is obstinate and won't listen to healthcare advice. So relieving yourself of that moral burden by saying, I am helping the patients take small steps, even if they aren't giant leaps. I'm kind of letting it roll off of my back when I have a patient who doesn't want to listen to medical advice. And I am feeling I'm acknowledging that I need to grow my knowledge in areas. I need to do continuing education. That first year, the job doesn't really end when you clock out. You have to go home and read. You're still working hard. You're still trying to get more knowledge and gain more knowledge. Because if you run across things that you're not familiar with, you're going to go home and want to read about it. And so the next time you're seeing that or seeing that patient, you're able to have better answers. And that's also going to help release some of that moral burden, building your knowledge base. How to how to address the lack of confidence. Again, you need to acknowledge those feelings, reflect on your growth. Do give yourself positive self-talk. Look, what I'm able to manage now. At the beginning, I was only able to manage about 12 patient appointments. Now I'm up to 16 patient appointments per day. I'm able to consistently get out of the rooms on time, or I'm able to consistently take the time to allow for patients to actually have the time to ask questions. I'm able to review their chart quickly enough, get my things taken care of that I needed to take care of, that I am giving them time to ask questions. So look for feedback, seek mentorship, identify those areas of weakness and study at home. One major thing I think people struggle with as far as time thinking, critical thinking, things like that, is coming up with your differential diagnoses and moving that to a plan of care. So what kind of steps do we need to take when we are sitting there with something like a cough or weakness? These vague symptoms that could be a million different things. How do I build a differential and move that forward to a plan of care? So first, you need to identify the red flags. So you need to be familiar with some of the major vague complaints and what are the red flags that could cause that major vague complaint, like a cough. Okay, you've been coughing for more than 30 days. This isn't acute anymore. Is this quietly heart failure? Is this COPD? Is this cancer? Is this asthma? What can we do to kind of rule out some of those things? What kind of labs could I potentially order so I can identify the red flags versus, oh, is this just GERD irritating the larynx and causing this cough? Okay, let's get the heartburn under control. We should see the cough decrease. Oh, your asthma inhaler's expired for 2 years. Let's get you a new one. So first look for the red flags, either through diagnostics, labs, things like that. And then after you get to that stage, then you can start looking for things that are more common. Again, that's number 2, is which diagnosis has the most positive findings and is it common? Sometimes I'll work with students doing case studies and they'll come up with these really off-the-wall differential diagnoses that only match one of the symptoms. And the really important symptoms for that differential diagnosis are lacking in the patient we're looking at. Where there is another differential diagnosis that has a lot more positive correlating findings and it's a more common condition, let's start with that one. Let's start with a thing that matches more symptoms and is more common. Often if I start asking specific questions about, and you can ask these to yourself, okay, if they were to have this condition, they should have this symptom. They should also have to have this, this, and this. And they don't have that. Just because this symptom matches, I can still keep this on my differential list, but it's not number 1. It's not the first thing I'm looking for. I'm looking for the thing that correlates the most. So choose your diagnosis and your versus diagnoses to work with. So you could have your primary diagnosis that you think that you're dealing with, but you could also have a rule out. So it could be, is this COPD or is this CHF, where we have wet lungs, we have risk factors for both. And so when you end the appointment, you may still have a versus diagnosis. You haven't picked which one it is yet because we need further testing or diagnostics. You also want to utilize evidence-based guidelines when you're looking things up. I actually have both of these books right here that are on my screen. And these are absolutely fantastic books. So this one's the Pocketbook of Differential Diagnostics, and this one is Differential Diagnoses of Common Complaints. And so the way that these books are set up is they're based off of more symptom-based type things. Again, those are some of the more difficult things to work up, is when they have a vague, non-specific symptom that's not just, oh, look, your A1C is 10. These things are a little more difficult to work with. Like this chapter is dizziness, lightheadedness, and vertigo. And it helps, and it walks you through what kind of diagnostics and tests you should be doing to help you parse out which issue is causing their dizziness, lightheadedness, or vertigo. Pain in the upper extremity, limping in children, menstrual irregularities, insomnia, heartburn, ear aches. What other things we have? Constipation. So it helps you walk through how do you parse out the cause, what kind of diagnostics and assessment findings do you need. So that one is the Differential Diagnosis of Common Complaints book. The other one, the Pocket Book of Differential Diagnosis, is set up very similarly. I think it's a little bit more exhaustive. It's got a lot more symptoms. It's got some pictures. It's a little more pithy. I think this one's long chapters that walks you through it in a very detailed way, and this one's a little more short. So that's why it's more of a pocketbook kind of a format. And so if you go over, like it's got about 4 pages on breast lumps with some pictures, some differential diagnoses, clubbing of the fingers, what could be causing that. So causes bronchial carcinoma, chronic suppurative lung disease like emphysema, CF, interstitial lung disease. And it even gives ratings, whether it's more likely or not. So like if it's more likely, it's got a green dot next to it. If it's less likely, it's got a red dot next to it. So it's a really helpful way, a really great resource to start with differentials that are not straightforward. Like hypertension, you can diagnose that really easily. It's really obvious they have hypertension. It's 160 over 110. It's really obvious they've got diabetes or thyroid disease. It's when they come to you with the vague complaints that it gets difficult. Insomnia, weakness, fatigue, things like that, where you have to start trying to put things together and figure out what's going on. A good guideline, especially for your first year, if you see a patient twice for the same thing, sometimes the third visit they come in, you're going to need a second set of eyes on that patient, further workup, maybe a specialist or referral, further diagnostic testing. Don't just keep throwing medicine at it. I have 2 big examples for that. So a young lady in her 20s was coming in for UTIs. She was a virgin, practicing good hygiene, no autoimmune conditions, no immunodeficiency. And she came in 3 separate times, and I was the clinician who saw her the third visit she came into the office. The first 2 visits were a couple of months apart. I think she was given macrobid and then maybe a penicillin for her UTI symptoms. And she comes back to me for the 3rd time, has no risk factors. This doesn't make sense. She's completing her antibiotics as described. There doesn't seem to be any hygiene issues, wearing cotton underwear, no soaking in. I mean, she was doing everything right. There was no good reason for this to keep going on. Well, at this point, no one had done a UA on her, and probably a UA should have been done maybe the 2nd time she came, because that would be considered failure to treat, because her symptoms came back after that first round of antibiotics. So 1 round of antibiotics, 2nd round of antibiotics came to me. And of course I got a UA on her, and she grew out something super funky that was resistant to like everything. And we had like 2 options. And so we used that, and we were able to, I also referred her out too, because it was typically bacteria that we see in people who maybe have like some reflux or something unique like that going on. So don't let it come by. It had been 2 or 3 months between each appointment. I could have probably justified a 3rd antibiotic. I could have somehow maybe justified in my head to just give her another antibiotic, that it was unrelated, that there's some hygiene issue. But we were just basically kind of killing it off a little bit, and it was coming back angrier. So I got the right antibiotics for her. I didn't let her go home without doing further testing that had been done previously, and I referred her out because it didn't quite fit what was grown out. That 3rd visit's really important. Another time I had a gentleman come in, it was over the course of a winter, and so the first 2 times to me it looked like he had a virus. He had a cough, and so we were treating the cough. It was the time of year for bronchitis, so the first 2 times he came in, he looked fine. I was like, all right, we just got a lingering cough, so let's keep addressing that. You doing honey, drinking warm liquids, Tessalon pearls aren't working. Okay, so we're just kind of addressing the cough on the 2nd time. He comes see me a 3rd time a few weeks later, and he's not the same color, like his skin color was ashen, and he just looked wrong to me. My gut fell when he walked in the room. I'm like, oh, we're not dealing with bronchitis. Something else is going on. Same complaint. I have a cough. He looked bad, and I'd done his vitals. I'd done his blood pressure at every visit. Everything checked out normal. Lung sounds were pretty clear. Heart rate steady, stable, no murmurs, nothing. There was nothing that I had seen on those first 2 examinations. The 3rd examination, I don't have an EKG machine, but I'm assuming he was an AFib because his pulse was all over the place. And so he was probably in paroxysmal AFib, going in and out of this for who knows how long. And I sent him to the ER because, you know, undiagnosed AFib, he looked decompensated to me. He looked bad. I mean, my gut just said, no, this is not good. I'm not going to send you home a third time with cough medicine. And I sent him, and he was in heart failure, not previously diagnosed. And I could have just again considered, oh, it's winter. He's still got bronchitis. He just feels puny. Maybe he needs some fluids or something like that. I could have, you can write it off, but I don't like those third visits if you don't do something different on those third visits for the same problem. So use your gut. My gut saved me in both of those situations. And so those are some of my prime examples. What kind of resources do I like to use? Epocrates are up to date depending on which one your company pays for. You can kind of go either way. I've always used Epocrates. My brother's a physician. He uses up to date. Sometimes I'll call him and ask him what his up to date says for something. And it's pretty consistent with what Epocrates is saying or other guidelines that you can get out there that aren't $500+ a year. But if your company pays for up to date, use it. That's great. Epocrates on your own is about $175 a year. If you're a student, you can get it for free. You just have to email the company. And I believe Up to Date does, if somebody knows, they can tell me in the chat. Up to Date during schooling either does half off or free. I think it's half off. But if somebody knows, let me know what they're doing right now because they've changed it from year to year. EMRA can be used. It can be used as an app. Sanford can be used as an app or a book for both of those. That's got your antibiotics, your antibiograms. Medscape and MedPulse are apps that I have on my phone just to read from time to time as far as updates and things go. I also recommend having GoodRx and LactMed on your phone as far as other apps that I feel like I frequently use. Let me look at my tab for NP apps and see if I've added anything new recently. If you want to get better at chest x-rays, Sublux is an app that's free, Sublux. That one's really good. It helps with chest x-rays, long bone x-rays as well. Pearls, Pyrls. Pearls isn't bad. That one does have a cost associated, but they also have some free stuff as well. I like a lot of their handouts and charts. And then the Prevention Task Force app, it's under USPSTF, and that can just help you with guidelines as far as prevention and wellness. So you can put in their age and gender, are they pregnant, not pregnant, and do they smoke or not smoke, sexually active, things like that. And it can help you determine what kind of screening is appropriate for that patient based off of their demographics. And that's old. All right, what questions does anybody have for me? Any questions that you might have for me? And again, if you missed part of this, it is on YouTube. You can go back and rewatch the first half. There's a lot of information at once. There's so much I want you guys to know to be prepared to start that first year off. All right, I'm going to go ahead and cut the stream to YouTube. And then if there's anything you want to ask me here, I can turn off the stream and record.